Hey, welcome back, everybody. It's time once again for another episode of Health Talks with Dr.Trinh. The one show, maybe the only show that shows you the path towards a healthier life, one conversation at a time. And today we're going to have a conversation that I didn't ever think we were going to have. I didn't even know such a conversation was possible. We're going to talk with Dr. Trinh about medical malpractice for cannabis providers. Dr. Trinh, clue us in. What are we talking about?
Yes. I want to welcome Brad Hunt. And you're with ProMal Insurance. Is that right?
Yeah, I'm one of several founders of ProMal Insurance. That's correct.
Yes. And
what does it do? What is ProMal Insurance? Why did you create this company?
Basically, ProMal Insurance addresses the medical malpractice cannabis gap. So this is a gap in their professional insurance, their errors and omissions, as well as in their education about cannabis. So we are...
Education, I get. I didn't know there was any gap in medical malpractice. I would think that is such a litigated topic, such a huge concern for any sort of healthcare provider. It's such a huge cost. I would have thought medical malpractice was dialed in as good as it can be. But you're saying there's some sort of gap when it comes to cannabis?
Yeah, in any insurance policy purchase, it's very essential that your agent and you look at what's excluded.
Yeah.
You say, well, I'm a doctor. I wrote on this form, I'm a doctor, and I see some cannabis patients, and I bought professional liability insurance in case there's an error, right? And there's an exclusion in most, if not many, nearly all, insurance policies that physicians have today, that there's an exclusion for non-approved FDA treatments and medicines. So cannabis in all its forms has, minimal FDA clearance, and is going to take years for that FDA clearance. So if a physician has an action taken against them, even if it's one that, another physician said, well, as another reasonable physician, they didn't make a mistake and this lawsuit maybe has no merit, you still have to pay for that defense, and that's what insurance does. Right. So as the cannabis physicians work towards integrating cannabis in healthcare, we want them to be free to practice, and we want them to be educated.
So, all right, a lot to unpack there, Dr. Trinh. You're a doctor. You must carry various medical malpractice insurance things. Once upon a time, you as a physician would never, ever recommend or use anything that wasn't FDA approved. But now I'll give you a silly example. Isn't Botox was designed for, something, botulism or something or whatever. It had nothing to do with skin wrinkles, and they discovered surely by accident. So if I'm not mistaken, that's still not an FDA-approved use of that drug. Is that correct?
That's correct. It's cosmetically used. So that's a very neat point you pointed out, Brad. Because there's actually a lot of treatments that are used off-label.
That's what I'm getting at. I think there's more and more of treatments off-label, what the label being what it was approved for. We're now using things, to say nothing of herbal remedies or cannabis or other plant-based remedies, other things that haven't even been considered by the FDA but have been maybe used for centuries in traditional Chinese herbal practices or other sorts of things. There's a variety of things that exist to physicians' playbook these days outside of FDA-approved drugs, right? Mm-hmm. So if you're using any of these, you're saying you're at risk, potential risk. If something happens, then your insurance is saying, well, we didn't cover that.
Well, there's some distinctions between off-label use, if the FDA approves a drug and then a physician, uses it through, peer review and the standard of care, says off-label use. A great tie-in here, without getting too far down this rabbit hole early, would be ketamine. Now, ketamine is a Schedule III drug, and the current discussion around cannabis is the Department of Health and Human Services recommendation that it move, the DEA move it to Schedule 3, all right? So, well, ketamine is maybe utilized in other ways as a Schedule 3 drug, FDA-approved Schedule 3 drug, off-label, not as what it was approved for. Cannabis doesn't even have this in the ballpark. There is no, other than the very specific pharmaceutical drugs and synthetics and things that have been looked at. You can't. Cannabis is what? Cannabis is a plant. It's grown in Colorado. It's grown in California. It's grown in every state where it's legal.
Right.
The conditions of that state are different. Each plant is different. The cannabinoid and makeup of that plant is different. So, for the FDA to approve that, it's not a compound. It's many compounds. Dr.Trinh, how many cannabinoids are there that you know of? This is the word for association, right? This is
hundreds. Yeah.
Right.
And you're saying the FDA would have to approve each and every one of those compounds, those chemicals, that component of the plant, and give it some category, and then maybe your insurance company and say, well, okay, the FDA's looked at this, and you're using it either according to the guidelines or off-label, and would they still deny if a claim erupted, or legitimate or not? You still got to defend these claims, and that's what your insurance company is there to do. You're saying the insurance company would try and opt out, would try and use this loophole to get out of defending those kind of claims.
Well, this, I don't want to say that they, take advantage of a loophole.
They look for loopholes, but that's my words, and I tend to stick to it here. Any way they can get out of not, paying your, insurance coverage, if they can find a way to do it. But that's a harsh statement. I understand, right? Okay.
Well, I would say, the way we do get the question is, why can't my traditional insurer that I buy my malpractice from do this today?
Right. Okay.
Right. So the answer to that question is reputational risk. There's several answers. Just uncertainty around this FDA discussion we're having. Now, the FDA, you could say, well, they have to study it, they have to prove it. But the FDA has said, even with CBD, we are not structured to go through an approval process for a cannabinoid. They've said that.
Wow. Okay. That's a pretty bold statement. So they're never going to look at the potential therapeutic value of cannabinoids, or dangers or risks or advantages, because what? Because it's not something they're structured to analyze?
Well, they're not structured to handle this, in their own words. And that risk of, the FDA is yet to look at these, the scheduling is set aside. The FDA is not geared, in their own words, to look at CBD, let alone the 113 plus cannabinoids there are, let alone their interactions with terpenes, right, and so on. So they're not structured able to do this. It's going to take a long time. So the traditional insurers, back to that point, would say, well, the science here is unknown. There's risk there. There's a reputational risk as a large malpractice carrier to get into this cannabis game early. And we at ProMal Insurance have already worked with and have ongoing discussions with doctors like Dr.Trinh, other leaders around there. I'll throw out Dr. Jordan Tischler at ACS, Dr. Knox, Jessica, Rachel, and their mother, Janice. We have doctors who are leading in the cannabinoid space, and we're already working with them, so the folks that can direct this, which should be the physicians.
All right, so you found a gap in medical care coverage, this one line in there that most people would not even catch when looking at the exclusions. The exclusion being anything that, say it again, is non-FDA approved?
Well, also you'll see language in there. It might be not that point blank. You'll also see language such as federally illegal. Well, that's pretty broadly defined, and cannabis is still federally illegal.
Right.
Or, so that's in the current Schedule 1 environment. But again, it's the uncertainty, risk, the lack of knowledge around cannabis, the fact that large insurers do have money in banks, so the banking thing, there's all kinds of reasons that it's early. It's misunderstood. So it needs specialists in the field of medicine and insurance.
So before we talk about the solution, let me make sure I understand the problem. So currently there are healthcare practitioners doctors who are using cannabis or recommending or somehow telling patients, try this, try a cannabinoid, try something here for anti-inflammatory properties or for whatever. And if they do so, you're saying they have a potential, not a huge risk, but maybe some risk, that should that patient come back and say, this caused a problem and I'm suing you, they may or may not have medical malpractice coverage. They may not have errors and omissions coverage. They may not be covered in that lawsuit. Is that what you're saying?
I'm saying that, but it's a little broader, Paul, than you've kind of stated. That's typically what we hear, the physician that said, yes, you have cancer, go get cannabis. But think about it this way. Let me color it for you this way.
Okay.
And I've been working in healthcare for 25 years in risk management. And what you'll see, here's the experience. The state legalizes cannabis, right? And they say you have to have certain conditions. So you go to a physician and say, can you confirm that I have this condition? They say, yes.
To get your medical marijuana, for example, or whatever. Yeah.
Right. So imagine going to the pharmacy saying, hey, my doctor said, come ask you what I should take. That's what then happens. The patient goes to a dispensary and says, hey, what do you recommend? I have cancer. Right. The physician's been taken out of the picture there. Now that patient, right, that went to go see the doctor who went through the state requirements to say, yes, I confirm your condition, go get cannabis. That patient now goes and sees many other doctors, correct?
Right.
Who has one doctor? They might end up in an emergency room. They might end up in hospice care. They might end up having plastic surgery or a hip replacement.
Right.
They might end up at a specialist where they say, I am a user of cannabis. I am a state registered consumer. I'm on file and I'm allowed to go get it and consume it wherever I am legally able to do so. And so now you're my doctor. Do you understand the 300 different drug interactions that occur with cannabinoids?
No.
Right, because your healthcare system you work for said, I can't educate you on this. It's federal illegal. So
yes, right.
I'd rather you not engage. So doctors actually be telling patients they have to drop them. And the patients are saying, I'm just looking for some information. You're a physician. And my state says I'm allowed to do this. It's a medicine. It's not a drug of abuse. I'm telling you I'm on it. So it's not just the very few doctors that we're looking to assist that participate in the state's cannabis programs. It's those affected by the millions of people. We were just in Florida. I think it was literally, according to their Office of Medical Marijuana Use, 2 to 3 and some estimates even 4 million residents of Florida in the healthcare system using cannabis in that state. So it's all.
And that would then have a chilling effect with the doctors. They'd say, because of potential for medical malpractice, I'm not going to see you, I'm not going to advise you, I'm not going to talk to you because I don't understand enough. And therefore, one, because I don't understand, and two, because I don't understand, that runs the risk that I'm going to say something that opens me to a malpractice case.
Yeah, and you know what? In the malpractice world, there's a thing known as the sin of omission, where you've heard my case, my situation, the other drugs I'm on, and you didn't give me a viable treatment option. Now let's look at post-traumatic stress disorder. You see that the VA is making headway on doing some more research. That's in the news. We were just in a physician's show in Las Vegas known as Pain Week, where all the pain.
What an appropriate name. Pain Week. Let's go to Pain Week and let's have fun in Vegas and go to Pain Week.
Well, Pain Week is attended by saints because it's the physicians who take on the tough cases of fibromyalgia and pain and the disorders where cannabis is used mostly. Some estimates 60-70% of cannabis patients use it for pain.
Yeah, right.
So we wanted to talk to the pain doctors, and there was a lot of VA doctors coming to our booth saying, hey, let me tell you my story about patients using cannabis and PTSD. There's stories of my father suffers from PTSD. He was a maximum security prison guard for 30 years. I was on Xanax. Had a withdrawal symptom that was horrible. It took us years to get him well. And his physician told me if I explored cannabis, they'd drop him as a patient.
They drop him
as a patient, according to their legal department. I said, how is that not omission of care? I mean, that's It's not wellness. That's not allowing us to do something that may work. It's not even giving us a viable treatment option. But again, as to whether that option is good for the patient is not my call. I'm not a doctor. I'd refer to Dr.Trinh. But I just want, in ProMal team, we want to provide the environment where these doctors can practice medicine, not risk any civil kind of liability, and have the education, more importantly.
So what do you think, Dr. Trinh? Are doctors shying away from cannabis or cannabinoid products, even discussing them, for fear that somehow this will lead to a malpractice case?
Yeah, well, lack of knowledge. Unless you've studied CBD and cannabinoids, you don't have that knowledge base. And if your patient's on 10 other medications, are you knowledgeable enough to inform them which one of those medications may interact
right
with the cannabis?
So they inform you that I'm taking cannabis, or that I'm a legal user. I'm even a registered user, and where it's medical marijuana states, and you get a license, a card from the state saying you can consume this because your doctor has said you have these problems, disabilities, conditions, whatever it's called. You get qualified, you get a card, you go to your doctor and show it to me. They said, "You're doing that? I'm out. I'm dropping you." Because
that's an uncommon story there. I'll tell you another story, Paul, because it's relevant to kind of the question you asked there about talking to your doctor about it. Doctors in Colorado and California that we work with say, please tell people that when they speak to their anesthesiologist, if they're going to go in for surgery, and we heard this again at Pain Week unequivocally, that they should be very honest about their levels of consumption of cannabinoid medicines and even psychedelics. Because what we have is that when asked, are you abusing any drugs, that doesn't really ring with a patient.
Yeah, define abuse. I don't take that much.
About my health care. So when you ask the question of, are you a participant in our state's legal cannabis program, it's very relevant to understand if you are, it can affect the level of anesthesia you need, because patients are waking up, reported by doctors, because they're not disclosing their cannabis use. They require possibly some additional anesthesia. Again, I'm not a doctor, but we have a lot of anesthesiologists on our committees saying that, under anesthesia, it can cause waking up or issues during surgery, which you can imagine how harm could occur to a patient.
Wake up during surgery because you were using high levels of cannabis products and potentially didn't get enough.
Right.
Wow.
Doctors, right, but it's even in less, let's say, not surgery. Let's go and look at the continuum of care. I like to think about the continuum of care when I talk about healthcare. We have, home care, we have hospice, we have senior living, and I do a lot of work in senior living risk management. And I had a gentleman in Ohio this past week in an assisted living facility. So if you understand what an assisted living facility is, it's
you pay and they take care of you and they do everything for you.
But it's not a hospital, it's not a nursing home, right? So a gentleman was a legal cannabis participant in his state, and he was on his patio, and they called the cops on him. The cops showed up, and he said, "Here's my card," and they said, "Would you please quit calling us? This is this man's house, and we're leaving." So, many of those assisted living facilities also do have skilled nursing tied to them. It's, once your care goes a certain way, you end up there. So, we know that cannabis is going into those environments. So the medical directors of the facility should be educated, know what's being pushed on the drugs, talk to the families. Hey, if you're bringing cannabis in, you got to know that statins, it's an issue. We should talk.
I'll give you one more. This is going to take us down a little bit of a rabbit hole, so I'll try not to go too far down this hole here, but it doesn't have to do with malpractice, but it does have to do with assisted living facilities. There was a law that I think finally got passed here. We had the gentleman who was pushing it on several times on several shows, a Republican, longtime Republican lobbyist whose son, young 30-something-year-old son, developed some kind of deadly cancer and was dying. And they put him on fentanyl and some other things and zonked him out. And they all begged, please take him off of this. Well, he's in extreme pain. Well, he wants to say goodbye. He wants to say goodbye to his kids. We want to say goodbye to him. And so they tried to find a less knockout kind of thing, and cannabis was suggested. And the facility that was in, the long-term care facility, it was either the hospital or or they'd shifted him to long-term care. adamantly said, no way, you can't even bring it in. If you walk in the door, we're kicking you out, because we're afraid that if we allow this in any way, shape, or form, we will lose our federal funding, licensing, whatnot. It may work for you. I'm not saying it's not an option, but you either take our federally approved knockout drug or go somewhere else. And this gentleman had to fight for some time to get his several facilities. Finally did it, and it was called Ryan's Law. And the gist of it is, if I want to take something and I'm dying, I should have the right to do that and die with dignity the way I want to, not be forced to take something that changes my end of life scenario dramatically. I'm out. I can't talk to anybody, see anybody here. And it actually, as amazing as this is in California, again, it's pushed by a Republican activist, so this isn't a political left-leaning culture war kind of thing. He saw his son suffering. He saw there was another option. The hospitals were afraid to let him do it because of fear. Nobody's ever tried to remove somebody's federal license if there was no case on file that somebody tried to do this. But the fear, the chilling effect this might happen, which is what you're talking about, the fear alone is enough to prevent them from even considering it, or even, if you do it, then get out. You're not my patient. You can't stay here. We can't let you. We'll call the cops, all that kind of stuff. And the upshot is that law, I think it finally got passed, but it took 2 times through the legislature, because even our governor here in California, it passed through the legislature, and then the governor vetoed it under pressure from healthcare agencies, because they're like, are you kidding? You're going to open us up to liability here.
Yeah, well, there's some things unpacked there. I've been working in that space, senior living, for many years, and there's a couple different situations there. So the situation you described there, Paul, most of our senior living, the great work that those heroes did, especially during the pandemic, right, was it's paid for by CMS, Medicare, right, and that's a federal contract. So in that contract the healthcare facility has with CMS, it says you won't violate federal laws. They have, as business operators, they have no choice but to react accordingly. If they get shut down or the doors get locked by the state health department, we have to displace all those seniors. That's unnecessary, right? So, we
lose
feel
that investment, fire all those employees. Yeah, right. It's not.
We are working with ProMal. We work with state associations. So we working, like right now, we're talking to the Florida Palliative Care Association, right? I work with the American Healthcare Association. We're talking to the associations of these employers that do this work and saying, okay, let's start educating on cannabis. Let's ensure your medical director, educate them. There's a place to start here that's not violating federal law. It's coming in anyway, so we can't turn our head. People are sneaking into their loved ones because they, again, want to have that experience, because we have board members in that palliative care hospice space, and they tell a story of, when you can say goodbye to your loved one and you're present. Like when she said that story, she was lucid.
Yes.
And not full of opioids.
The whole point of this Ryan's Law was don't make them drugged and doped up here. Yeah.
Right. So if the physicians tell us they want to explore that, we're here to educate them and ensure them so they can go down that road.
How much, how active are you guys as far as number of cases defending, physicians and providers? Is this a huge problem or a small problem with a huge potential, but there's not a lot of cases?
Is it a perceived problem and that's causing the fear, or is it actually an active, ongoing fight that physicians are being sued and hospitals are being sued and facilities are being sued?
Right.
It's an active problem. I mean, Dr.Trinh can tell you, physicians get sued for supplements and aspirin. So cannabis is no different. It's even more sensational. And, there's an opportunity here, because one of the big myths that we deal with, even from the claimant side, the injured patient side, is that there's no standard of care, or there is a standard of care, right? So we want to be out there telling you there is standard of care right now in cannabis. Physicians are behind the curve. There are associations writing the standard of care in your specialties. We're working with them to do so. So that, saying that another physician, basically, here's a malpractice case. There's a doctor, the doctor's accused of a bad outcome, right? Patient's not happy. Well, if the patient's not happy, they're going to bring the action. You have to defend it. Another doctor says, well, I would have either done that or not done that. Right now,
that's what you're talking about, the standard of care, because when it goes to
care in a
court,
malpractice case,
right.
yeah.
Did
So
he or she
highly
violate?
oversimplified, highly. I could hear my legal counsel Jay say that. Highly oversimplified, but
Right.
the gist of it is: did you follow the standard of care, and was the patient harmed? And that's
Right.
the gist of a malpractice case, right? So, as to whether we have physicians right now. We had a physician who was treating a minor for seizure disorder. Now, when the doctor is treating a minor with cannabis, there's checks in place in some states, not all, where that physician is, highly encouraged, best practice, or if not the rule, work with another physician to say, okay, let's get the parent, the guardian to sign off, right. 2 doctors. Okay, there's enough look at this that we're going to proceed, right? It's a non-intoxicating, maybe more CBD-based
right.
cannabinoid, and then you go ahead. Well, one doctor lost the paperwork from the other doctor. An activist doctor said, in this state, I don't think you should be giving children cannabis. Brings an action with the state medical board. That's covered under different insurance, but it's still that litigation of the medical community right. and the misunderstanding. And, again, we're at ProMal scorekeepers. We want the doctors to come up with the standard of care, with the doctors to be doctors, right? We'll keep the record, tell you what you're all coming up with as the standard of care, provide the insurance and the education. Education is key here.
Wow. I didn't know any of this existed. I never thought about this. I would have never imagined it. I mean, how did you come across this and uncover this flaw in the arrangement, this whatever you want to call it, this gap, this problem?
Well, I'll give a shout out to some of my partners. I was asked by a good friend of mine named Darlin to meet a guy named Jay Shorey and Kurt Witchey and Doug Vahey and Chris Galgozzi. And this small team has worked for 6 years tirelessly to convince regulators. I want to tell everyone, this is not insurance that you would get some more specialty, like, hey, in London or in some Caribbean island.
Yeah, right. No, that was going to be my next question. Who underwrites this? Yeah, right.
Yeah, well, we are domiciled. When you sell insurance, at least one state you have to work with closely. And without using too much technical insurance terms, it's what's called admitted. It means that the state, in this case, Florida Office of Insurance Regulation, right, they looked at all this and they said, yes, this is a program that you can say we've looked at and approved the premium payments, how you guys control the claims, the questions you ask a doctor before you sell them the insurance. We've worked with them in some final stages, some tweaks, but we've been given the okay to go ahead. And that was a significant win.
It takes one state to do that, and then you can do this across multi-states?
Well, just like a business, you have to domicile somewhere. Hey, it's in Delaware, but not just making it haphazard. We thought Florida, the carrier that we work with, thought Florida was a good state they could work with and get it to be understood what we were doing. But I don't want to give the impression we've just worked with Florida. We've worked with many other state regulators throughout this process, and now we're able to work to get in other states in the very near future. The West Coast, New England, all the cannabis states that you think is traditional cannabis states.
Why Florida? I would think you'd be in Colorado or California. One, because it's a more liberalized environment. 2, because it's more pro-cannabis.
The Department of Insurance, you would say, why not be in that state due to the cannabis environment? But that really has little to do with how we would regulate and deliver insurance. So the insurance markets of certain states understand things that we do, like this, a specialty insurance plan, better. We've worked with states like Nevada, and their department was super helpful for us. That's where you go when you do a specialty insurance plan. Florida, Vermont, these states have been involved along the way as well, help kind of guide this. And finally, Florida was the best decision for a lot of reasons: regulatory, the cannabis program, the number of patients, the state of malpractice. It made a lot of sense to start in Florida.
So the standard of care for medical cannabis treatment. So you mentioned your organization provides that type of information?
What we do is we partner with state and federal, national level associations of physicians, like the Physicians Cannabinoid Council.
Yes.
Right? But others on a state level, like the Florida Society for Interventional Pain Physicians, the pain and anesthesiology doctors, the rehab doctors. the Association for Cannabinoid Specialists. They're working on, a specialty in this field. So when we work with the state association, they say, okay, our members come to us for education, insurance, and things of that nature. Well, let's form a committee on cannabis within that association and say, okay, how do the Florida anesthesiologists want to consider the standard of care for cannabis, right? And now that decision has naturally gone down to psychedelics and psilocybin, and there's
because that's re-entering. We had some. It wasn't on your show, Dr.Trinh. You had somebody talking about re-examining the use of psychedelics. It was.
He's a chief medical officer for Mind Medicine, which is a psychedelic medicine
taking
company.
Serious look at bringing psychedelics seriously back into the conversation about psychiatric health care. Which
There's
is
some
where
state plans that allow us to go down this road right now out there, and then again, it's a non-approved FDA treatment that with proper education and insurance, we'd like to empower physicians to explore.
I am fascinated. I'm seldom at a loss for words, Dr. Trinh can tell you, but I'm at a loss for words here. It sort of reminds me in a weird way. I was at a symposium here at UCI. We're at the University of California, Irvine's Applied Innovation Center. They have all this cool stuff. Never anything like this, but they talk a lot about autonomous vehicles here. A lot of research being done. Irvine's a big center for electric vehicles and autonomous vehicles. I don't know why, but there's a lot of it here. And one of the things after the whole panel, everybody's talking about the excitement of autonomous vehicles and the driving, and then this lawyer got up and did what you did and talked about the legalities, the liabilities. If a robot car hits somebody, who do you sue? The manufacturer of the car, the manufacturer of the software, the manufacturer of the guidance system that the software relied upon here. Who gets sued? And everybody was like, oh my God. And they said, until you figure that out, people aren't going to do this because it's going to have a chilling effect on the entire industry. You're saying the same thing. Until somebody figures out standard of care for all these kinds of use of these compounds, and some sort of agreed, these are the safeguards you should in place. Have two doctors advise them. Don't do it with minors. Do under the circumstances. All these kinds of regular things. This is a way a standard, safe guideline for use, recommending these products. And then, only then, can you actually say, and with a standard of care, then we can insure this non-FDA approved thing and give you a specialty insurance plan that will prevent you, that will defend you should any of these maybe serious, maybe frivolous lawsuits appear. You'll be covered.
Yeah, that and the education. It's the reason I keep stressing education is because physicians are working for healthcare systems and employers who typically provide them with that education, or their associations. They seek their education from those two places, right? Or their peers, right? And their employer, due to the federal illegality, has not been able to train them.
So won't even talk about it. So if I'm at a hospital and I'm an on-staff physician, Dr. Trinh, I can't go to them and say, what about my patients talking about cannabis, and should I, whether or not even I recommend it, what do I need to know about their use and its interaction with anesthesia and other drugs and other things I'm recommending here? They won't even talk to you about that?
Well, not only that, Paul, let's leave the medicine on the shelf, for a second. There's a system in your body. Maybe Dr. Trinh would be best to talk about it than me.
System.
Yeah. Maybe I'll throw you the softball here. It's the endocannabinoid system. Your body. Maybe we could talk about anandamide and how your brain even makes cannabinoids. Dr. Trinh.
And the lack of understanding of that. We've talked about that. Talk about that again, Dr. Trinh. Here's a system in our body, like our vascular system or other stuff. And it's only recently even discovered, very little understood or studied.
Right.
It's
right. And Paul, the malpractice risk can come from not understanding that system, which regulates the other systems. So that lack of knowledge is therefore a risk to the physicians as well.
Then I got to sue the medical school that didn't teach me about any of this stuff here.
Well, there are some that are starting. Look at University of Maryland. I'll give them a kudos. They have like a master's level type degree you can get to bolt on to your PhD in medicine. So there are some programs out there that are starting. We were talking to University of Central Florida, University of South Florida, when we were in Florida last 2 weeks. So there's a lot of interest in also the residents. When we go to medical conferences, we get talked to by the residents. They're like, hey, this is going to be our career. We need to get in on this kind of now. So
because the cannabis ship has sailed, people are consuming and using. The laws have changed dramatically in the last 10 years and continue to move in that way.
The creative folks that create the medicine are at it every day, and they're growing in their knowledge and capabilities exponentially, while healthcare is on the sideline, not even paying attention.
Yep.
I mean, it's a
That's
problem.
the gist of it.
It's pretty much because it's locked in jail.
Locked in jail, right? We're afraid to talk about it. We're afraid to let it out. We're afraid to look at it. Yeah, exactly.
But patients ask the physicians about it 3 times a day. So what are they to do? They are to engage. They have to.
Yeah.
Or they say, because saying I don't know isn't enough. You're saying, well, if I go and do it anyway, I went to you, and then there's an interaction in my anesthesia, I'm going to go back.
Here's a troubling pattern I see, because I also work with healthcare systems. So what'll happen in some bigger healthcare systems where this is being asked constantly, they'll say, one doctor. So we work with the Ohio Medical Marijuana Physicians Association. The physicians that participate in the cannabis program in the state have formed an association. We work with them. And I hear the story from some of them that, I'm the only person in my system. I'm the cannabis doctor.
Yeah.
Right. So they'll send them to me. I'll confirm. I'll send them back. And I said, well, then what happens? Do you coordinate on the care? No. There's no discussion on the care. With 2 doctors, one just sent one to the other and didn't even talk about the follow-up. We need to fix that.
Because there's no other doctor to talk to. We're all.
Well, you can call the cannabis doctor that you sent the patient to and say, hey, doctor, I sent this guy there. Maybe let's talk dosing, and let's talk a little the strain or cannabinoids or terpenes, or what should he be on? Because there's doctors that are trained to that level now that can say, hey, caryophyllene might be good for his anti-inflammation and so on. Again, I'm not a physician, but this is what I hear.
What do you think, Dr. Trinh? Is this the coming wave? Are medical schools going to offer extra certificates or whatever things studying this? And then when will there be more and more trained physicians on staff who you can refer to and ask about this stuff and consult with?
There's absolutely not enough currently, and this is a situation where the patients are there waiting for the science to catch up.
Yeah.
Yeah.
Or the patient knows more than the physician. Yeah.
Absolutely, patient know more than the physician, and it's a shame actually that there's not more emphasis in this, because this is potentially looked at as plant-based medicine.
Right. And right. Correct me if I'm wrong, Dr. Trinh, but your story that you told me originally several years ago when I first met you was you had a private practice, I think in Laguna Woods, which is a retirement senior community, and your patients kept asking you, and you didn't know. So you started investigating this, and that's what led you down the path towards understanding.
The physicians we work with, that story's pretty consistent.
Yeah.
You wanted to know because they're already ahead of you. They're using this stuff. Hey, my friends used it. I used it. I want to get off some heavy medication, and I've got inflammation. I got all these other things, or all the other conditions people using cannabis for. They were anecdotally hearing about it and trying it and coming to you for confirmation. You went, I don't know.
Right. But even within the cannabis culture, I'd say, there's a lack of understanding of medical applications that are growing and that are becoming more sophisticated. I mean, I give you an example of cannabis hyperemesis syndrome. Have you ever heard of that, Paul?
What? Say that one again here.
Did I say it right, Dr. Trinh?
Yep.
Okay. So, basically, you've heard that cannabis gives you the munchies, right?
Sure.
Right. Well, cannabis has what's called, for the physicians out there, the biphasic curve, right? Where there's a sweet spot, there's a Goldilocks zone where it really makes you do and feel what you're looking for, right? Well, once you go over top of that and you overconsume, and today it's easy to overconsume because of the potency of cannabis medical products. Like there's a debate out there right now is potent cannabis medical cannabis? Well, the legislatures have defined it that way. Because the difference between a medical dispensary and a recreational dispensary is the potency of the cannabis.
I didn't know that.
Or in Michigan, it's 15% off your purchase. That's it.
And I'll go one more little rabbit hole. That's why the whole Physicians Cannabinoid Council exists to verify what's in the darn thing. It's not just enough what is the potency and how does that affect. You don't even know in some cases what you're buying. It says on the label it's this, but that doesn't mean it's really there because there's no oversight. There's no investigation.
So patients present in emergency rooms with this cannabis hyperemesis syndrome. It's a vomiting disorder. They typically say, when I take a warm shower, the nausea goes away. That's kind of a confirmation that you're maybe over consuming. You got your vape pen, you got your cream, you got your,
under your tongue, you got lozenge, everything.
You're consuming maybe 5 grams of cannabis oil a day. Maybe we should slow down. That's the reason you're having this discomfort in your GI tract. Right. But physicians may not catch it and treat it as, irritable bowel or other things. And we've had cases like this, actually. Yeah.
Yeah. Wow. So in a nutshell, what is it that a physician needs to know with pro-mal insurance? They obviously, most physicians are not aware of the need for this gap insurance, right?
And if they were, wouldn't have a clue where to go get it or anything about it, right?
Right. Well, we simply have conversations with physicians. The education helps. Once we have right on our website, if you go on promalinsurance.com and you click on our education tab, there's a free CME for physicians on there. And it's
what's a CME? I don't know what a CME is.
Okay, so that's a great question, Paul. Thank you for not letting me talk jargon. It's basically a credit towards your medical license. You have continuing education requirement to call yourself a doctor and renew your license.
Right, sort of continuing education.
Level. Right. Our education's to that level. It's been evaluated and it's been given a PRA Category 1 credit. That means something to physicians.
Because to maintain your license, like any license, whether it's a lawyer or a
cannabis, you might as well get a credit towards your license, right?
There you go.
Yeah.
And the specific one on there right now is the endocannabinoid system, the ECS. So they can learn about that free. Go on the website, click on it, and the CME is covered by our education partner, Pivotal EDU, who I'd like to give a shout out to today. There's also another class on there, Cannabis Grand Rounds. Cannabis Grand Rounds is a monthly live thing like we're doing here, where we bring the cannabis community who makes the medicine together with the healthcare community to close that chasm that I talked about. Also, sometimes we'll just have physicians working with other physicians on a CME level for that grand rounds, doing a true rounding of patients, doctor to doctor, on cannabis outcomes, things that should be used, best practices, standard of care, and so on. So you can see a recording of cannabis and drug interactions. It's free also on our website there.
And dare I say that's been one of the things I've questioned from the beginning when we have millions of people, not just this show, lots of shows. We do lots of business shows and health shows. And everybody starts with, it's plant-based. You can't get sick. You can't die. But then, as Dr. Trin's pointed out, I think, there are interactions like any compound. Two things don't always mix well together, and it depends on
the cannabis you consumed when you were in high school and you got a sandwich bag off your buddy. That's not what this is.
Who are you talking about here, right?
People, come on, Paul. So people still believe. People still have that mindset when they hear cannabis, and I gotta say, it's many, many things. I mean, how many ways can you combine 113 things?
And I was amazed, years ago when we started this conversation with Dr. Trinh, I went home to my wife and I said, did you know that there's such a thing called CBD, one of the compounds of cannabis? And people are using this for anti-inflammatory. She says, yeah, we got some in the cabinet right over here. I said, what? In my household, there's already this here?
You get arrested, Paul.
Yeah. Do we hide it? Do we have grandkids? Whatever. What are you doing?
Yeah. Well, hey, if people want to get educated on cannabinoids, look up CBN. Look up CBG. Just Google how many cannabinoids are there and dive in. Go ahead.
All right, so we've got a three-pronged problem again here, as always, and that seems to be why it's so complex. One is you've got a federal system that says this is still not studied, not approved, not going to talk about it, and that creates a chilling effect down the line. Ain't going to talk about it, ain't educating anybody, ain't interested, but the public is already ahead and trying it and using it. And if you don't get up to speed, then maybe you're doing them a disservice and maybe even opening yourself to malpractice. I told you, doctor, I'm doing this. Why didn't you warn me about anesthesia and all this stuff? Why didn't you tell me? I alerted you to this, which is then goes back up the chain. Then I'm not going to talk to anybody that says they say the word cannabis, you're out of here.
Yeah, and the people who've had that experience, I think we could do a better job in healthcare.
Wow.
Absolutely.
Wow.
How are you getting the word out about the monthly cannabis grand rounds and all that? I'm sure if I told half of my doctor friends, they would be interested in checking it out.
How are we getting the word out? Well, I'll tell you what, we just said today we're going to make T-shirts. We did a road tour.
That's it. Now we need to have TikTok videos of dancing doctors or something.
On tour. So yeah, we hit Florida. We've been in Vegas. We've been around the country meeting with physicians face to face. We went to Pain Week. We went to the physicians anesthesiology conferences. So we're out there. Check our website. We have where we're going to be. We do host the monthly events, the grand rounds. That's how you can connect with us. And we're working again with physicians associations because they go to them and say, you guys should be giving me, I pay dues every year. Give me the education. Give me good insurance.
I'm going to suggest that you take it one step further. And this is a self-serving comment because I believe in this, but you should do more of what we're doing and create podcasts, conversational, not educational videos. You need that too. But conversations where people can say, what? Why? I never thought of that. Come on.
That's a great recommendation, Paul. A lot of our partners that we work with do have events like this, and, we're building community here so we can get the word out. So thank you for helping.
Yeah. It's, again, a whole area I would have never thought about, never dreamed was where people are racing ahead, experimenting with this stuff. The public's more open because they're all aging baby boomers like me, and we're looking for alternatives. We don't want to be drugged out. And so we're looking for other cures and problems and potential use of this thing. And we're open-minded and maybe because of our youth open to this whole discussion here in a way that others aren't. It's there. It's happening. It's growing. Everybody knows it. And yet you're saying, whoa, behind the actual, because of the federal ban, and that leads to a federal chilling effect on information and discussion. And then therefore, because they're not educated, and because this gap exists in their current malpractice coverage, those two things I don't know, and what I don't know can cause me harm. I'm going to stay away from this as far as I can.
Paul, you want a job?
Wow, I'm telling you, this is a big story. We just broke a big story here today, Dr. Trinh.
Absolutely. So these monthly grand rounds are virtual and they're free? They're
virtual, they're live. There's a free version. They're discounted heavily through the ProMal site. Mm-hmm. I think it's just a few $100 for 12-month subscription. So yeah, check it out.
Check it out. And the website again is?
www.promalinsurance.com. That's PROMAL altogether. Insurance.
And why the name? Mal from malpractice. Why pro-mal?
Yeah, professional malpractice. Yeah. Again, it's stigma. You won't see a lot of cannabis leaves on our website because it's not about that. It's about healthcare.
Right. And wow. Okay. So and I would think, like you said, Dr. Trinh, more and more doctors are being asked about this. They got to be all the time. So they're curious and they're wondering and they want to know more. Where do they go all the time? If not to things like this. You're saying that if I don't know, I'm a pediatric doctor, I'm a something, and my association doesn't have continuing education programs about the cannabinoid system and the interaction, all the stuff he's talking about. I can't go to my association and get this. I can't go to my hospital group I'm a part of and get this. Nobody's talking about it. Is that what I'm hearing here? I thought they were having those discussions all the time. If I was part of some big medical group,
Well, I can tell you that I do a lot of healthcare conferences around the country every year, and it's on the agenda. There are breakout sessions. It's becoming normalized. But I've attended some of the education that was a little behind or maybe inaccurate. Depends on your position. So I'd say check your sources, get a variety of sources. Make sure, like your association you go to vet your education. So when you take it, it's quality. If your local state specialty association is not embracing cannabis. Well, there's national associations you can join today, like PCC and our other partners. You can check the partner section of our website. So access to the education is not the problem. It's the, we've made it affordable, we've made it free, we've made it accessible, and we're coming to a town near you. So, take advantage of it.
Take advantage of it. Well, so much. Take us out, Dr. Trinh. This was a fascinating discussion. I'm still going to be thinking about this an hour from now here going, really?
Well,
I can't believe it.
Hey, let's do a follow-up. Let's do another one. I'll tell you how it's going.
We should, because this is a problem that so many we've talked with Aline and others. Cannabis is there in the public's mind. Why is it still struggling to gain traction and to gain a marketplace and to find a predictable methodology for working this into our system, our society here? A lot of
because of the gap between the cannabis industry and the healthcare industry. That's why.
Yeah.
There you go.
Probably because it's not owned by pharma yet.
Well, come on, pharma, jump in, buy some of this stuff here. Let's go. It's just another plant. You guys investigate plants and turn them into synthetic compounds. Why can't you do the same thing here? Yeah.
Wow.
Wow
this
is the
great.
key word.
We definitely want to do a part 2 sometime, Brad, and take a deeper dive into
and
what
stick on. I'll give you some thoughts about creating a podcast if you're interested. I think you.
Let's talk.
The key thing from my perspective is really just getting that education out to the docs who don't even know this exists, that this gap exists, and especially if most docs now, we all know all of our patients are taking products.
You know what? I'll give you the biggest pushback we get, and maybe we can kind of end on this.
Yeah.
Okay. The physician says, I didn't prescribe it.
Right.
Okay. Well, for as far as civil case goes, where that patient came in and said, hey, I'm taking these other drugs and you didn't do the proper background, whether or not you were the one that confirmed they had another disorder, which is irrelevant. Right. As far as malpractice goes. So if you're not the prescriber, but people are walking in, this is pay attention. You should pay attention.
Absolutely.
Otherwise, you're going to do what? You're going to shut your eyes and hope it doesn't affect me.
Or you might have a patient who doesn't have a good outcome, and they might not be happy with that.
And that should be concern for everybody, not just from a legal standpoint, but from a physician's
not about us
do no harm. Yeah,
clever thing in a policy, right? It's about making people well. That's what this is about for us. Right?
Take us out, Dr. Trinh. We're going to definitely have to hear more about this. This is a bigger issue.
All right, thank you so much, Brad, for coming on. So ProMalInsurance.com. Everyone come take a look at it. I'll definitely be checking out the monthly
roundtables. Right.
Looks kind of neat.
Cool
so
stuff.
Thanks so much, and great conversation today.
All right.
Thanks, Brad.
I'm looking forward to the next time, and it was a pleasure. Thank you.
All right, stick around. We'll give you some other thoughts, or maybe you can give us some other people we could talk to about this. Hang on.
Sure.
Well, there you have it. One more reason to tune in. That's exactly why you got to tune into Health Talks with Dr. Trinh. Who knows any of this stuff? We're all trying to live a healthier life. What are the barriers we're facing, legal and otherwise? Only here on Orange County's only community radio station, OC Talk Radio. Streaming live from our studios here at the University of California, Irvine's Beale Applied Innovation Center.